Welcome, everyone, and thank you for joining us today. We are starting our session today with lots of great information, lots of amazing reasons as to why we come together as Moms Stop the Harm to support all of our members and just partners in general. So today's session is called From Awareness to Action, and we're doing it in honor of International Overdose Awareness Day. Of course, with it being 2023, this is where we're at in life and in marking this moment in history, and this is where our discussion continues. We'd like to start off today. I guess I should probably introduce myself. So I'm Tyler Savard, the Acting Director of Operations for Moms Stop the Harm, and our panelists are going to be introduced here in a moment. But I'd like to start off today with our land acknowledgement. So we would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility to care for the lands, to strengthen relationships between nations, and to improve our own understandings of local Indigenous peoples and their unique histories, homelands, languages, cultural practices, and spiritual beliefs. From coast to coast, we acknowledge the ancestral ceded and unceded territories of First Nations people, Inuit, Nanagat, and the Métis homelands of First Nations, Inuit, and Métis peoples that call these lands home. I would now like to introduce our Vice Chair of our Board of Directors this year, Traci Letts. And Traci, I'm going to turn it over to you.
Hi, thanks, Tyler. In addition to the land acknowledgement, I would like to just briefly touch on a few things. So I'd like to take a moment to acknowledge the grave impact the toxic drug supply has had on our communities, particularly on our Indigenous communities. The devastating consequences of this crisis disproportionately affects these communities, exacerbating existing inequities and vulnerabilities. We acknowledge the structural injustices that contribute to this disparity and commit to addressing the root causes that perpetrate such disparities. As we come together, we strive to amplify the voices of those who have been marginalized and disproportionately impacted, listening to their experiences and insights as we work towards meaningful solutions. By acknowledging the intersectionality of the toxic drug supply crisis and with historical injustices, systemic racism, and colonial legacies, we hope to pave the way for a more just and equitable future for all. And you have moved on. And so this is Mom Stop the Harm's Education Committee, which has specifically produced this informational webinar to coincide with International Overdose Awareness Day. And knowing that many of our members that participate in IOAD events throughout the country, we feel that this webinar is addressing some of the most pressing issues that would be beneficial resource to have in everyone's toolkits. When we get asked questions that we either don't feel confident or comfortable answering, the more information or resources that we have at your fingertips, the better equipped you will be able to tackle and help educate interested media and community members. It is our hope that we can address relevant issues and answer questions in a clear, concise way so that you can respond similarly when required. Today's webinar is part of a series that the Moms Stop the Harm Education Committee will be producing. This one will touch briefly on a few relevant topics, while the others will be taking a deeper dive into Moms Stop the Harm's advocacy work as it coexists within our visions, our values, and mandate as an organization. Mom Stop the Harm advocates for the change of failed drug policies. We provide peer support to grieving families, and we assist with those with loved ones who use or have used substances. So as we can kind of move on we've got some great panelists here today, very experienced, very knowledgeable, and I would like to introduce them before we get started. We had Katie, who was one of our board members that was going to join us today. She's unable to attend, but she was extremely important in providing insight for us to put this webinar together. Corey, another board member, new this year. He's a registered nurse that works on the front lines. Leslie McBain, co-founder of Mom Stop the Harm. Without her vision, along with the other co-founders, we wouldn't be where we're at today. and Emily, coming from the Maritimes, has an amazing family perspective. So, maybe a brief introduction yourselves, if you just want to, kind of say hi, say who you are, and how about we start with Emily?
Hi, I'm Emily Bodechon, and I'm in New Brunswick. So I came to Mom Stop the Harm when my son was struggling with substances, and he suffered some um, really severe health conditions because of the harms and his treatment in the healthcare system. And so um, he's currently in recovery, and so I advocate for changes to drug policy, and I also facilitate a holding hope group so that I can give other families the space to be heard.
Thank you, Emily. And Corey?
Hello, my name's Corey. I use he, him pronouns. I'm a registered nurse. I'm joining you today from the unceded stolen territory of the Cowichan tribe in what is colonially referred to as Duncan. And I have spent the last 3 years working primarily in prescribed safer supply programs in the scale up and development of flexible models for prescribed safer supply. And I'm also the president of the Harm Reduction Nurses Association.
Thank you. And Leslie?
Hi, everyone. Leslie McBain here, co-founder of Mom Stop the Harm, along with Petra Schultz and Lorna Thomas. For about 8 years now, almost 8 years, we've been working on working to advocate for policy change, as we realize that the policies of not only federal government but provincial governments have not been proactive in stopping the harms. I lost my son in 2014 to an overdose of prescription drugs, and that's what propelled me here. I work on a lot of different fronts, and I'm really honored to be here. I am on the unceded stolen territories of the Wasanich people, with whom we communicate and learn. Thanks.
Thank you, Leslie. And even though Tyler did introduce me, my name is Traci Letts. I'm the vice chair of Stop the Harm, and I'm calling in today from the stolen and unceded territories of the Kwantlen, Katzie, Matsqui, Semiahmoo. And they just added a new one in the Coquitlam First Nations. And welcome everyone to our inaugural part of our webinar series that we're planning on doing. So we're doing this as a question and answer type format, and we're really going to be dealing with what is harm reduction today, what is safe supply, and looking at it from a couple of different lenses and views. And hopefully the answers that we provide will enable you to move forward yourselves when it comes to talking in regards to the subjects. So our first question today is really kind of what's going to start this off is, what is harm reduction and why do we need to advocate for harm reduction services in this country? And I think we'll turn that one over to Leslie to get us started.
Okay, the term harm reduction in its simplest form, of course, is to reduce harms. Why this would be controversial is actually quite astounding. What it means to us, before I get really political here, but what it means to all of us are things like naloxone and naloxone training, detox, evidence-based recovery facilities, housing, safe supply. There are many. I mean, you can think of your own reasons or your own definitions of harm reduction in the realm of what we're talking about. OPSs and safe consumption sites have saved thousands of people. Drug testing is harm reduction. Anything that will work to reduce harms for people who use drugs is harm reduction. As I say, why this could be controversial is a little bit beyond me, but we work with government to try to involve and improve and expand on harm reduction services. Harm reduction is a necessary band-aid for the crisis of toxic drugs. We wish everything was such that we didn't need harm reduction, because everything would be harms would be reduced and people who use drugs would be safe and balanced and ready to maybe change their lives if they want to, but at least they won't die. I could go on and get political here about organized crime and the inability of governments to make changes, but I'll save that maybe for a little bit later in this program. Harm reduction also includes education, awareness of mental health and safety, and it must begin at a young age. So don't give up. Thanks.
Thank you, Leslie. Emily, did you have anything to add to that? Oh, you're on mute.
Sorry about that. Yeah, I like to put harm reduction in terms that people can relate to, so that you can relate it to other things in life rather than specific to people who use drugs. So harm reduction is a basic human right, and it is the government's responsibility to keep us safe from harms. And so examples in everyday life, there's food and drug regulation. When lettuce is contaminated with listeria, it's recalled and pulled off the shelves. There's child-proof covers on medication to keep our children safe from toxic poisonings. We have water treatment plants so that we don't get E. coli or salmonella from the water. There's warning labels on cigarettes. We wore masks during COVID. And it's the stigma with substance use disorder, where the onus is placed on the individual rather than on the regulating bodies to keep people safe. And so the general feeling is that people are responsible to reduce their own harms, when the reducing those harms is a lot of times unachievable because they don't have the resources to do so. And so as an organization, we advocate for harm reduction because the government follows public opinion, and that's how they decide to make policy changes, is through pressure from the public. And I have an example here in New Brunswick of harm reduction where they changed a law, and it's called Ellen's Law. And it was a few years ago, a young woman who was a very skilled cyclist. She was tragically struck by a vehicle and she passed away. And so the cycling community rallied together and they advocated for changes to make the roads safer. And so they implemented a law called Ellen's Law, and now it's law in New Brunswick that you have to give a 1 meter clearance for bicycles. And so that's an example where people advocated for changes to the law to reduce harm, and it was effective.
Wonderful, thank you. Do you have something to add, Corey?
Yeah, I mean, I think when a lot of us are first introduced to harm reduction, it's presented very much as a series of services. Services related to sex, services related to drug poisonings, preventing bloodborne pathogens, and that's not necessarily wrong, but it's also a very superficial way of looking at harm reduction. It looks like these types of services, like overdose prevention sites and safe supply, and we need those services, but that only represents the ways in which harm reduction can be delivered. If you take a minute and zoom out, though, you can also understand harm reduction as an underpinning philosophy of care. It's a way that we actually facilitate connections between people and health, connections between people and social services, connections between people and other people. It's rooted in a commitment to social justice, person-centered care, trauma and violence-informed care, cultural safety, reconciliation. And if you just look at harm reduction like a series of services, then you fail to see what it really is, which is a means to redistribute power and resources to people who typically experience structural violence, inequity, and marginalization. So it's about understanding risk. And by that stretch, harm reduction is both downstream and upstream. And I think it's really important because we need to advocate for harm reduction also because there are people who are invested in the status quo. We need to advocate for harm reduction services because they are evidence informed and they save lives. And we are still in coming up to year 8 of this public health emergency of drug poisoning deaths here in British Columbia.
Great answers from everyone. Thank you. And kind of moving forward, kind of in the news a lot lately, we've been, hearing about safe supply, hearing that it seems to be a huge topic, a speaking point for politicians. So they're weaponizing, politicizing this in a way that is detrimental. And so my next question would be, what is safe supply? And can you speak to the importance of safe supply? And I think we can go to Corey to start this one out.
For sure. Safe supply, it looks different to different people. A simple definition of safe supply could be the provision of regulated and predictable alternatives to the unregulated drug supply. It could be prescribed, or it could be purchased from a licensed distributor. It could be made available in a number of ways, depending on the substance and the regulations that kind of enshrine that substance. We have to be mindful not to co-opt the term safe supply, because at its core, the ethos of safe supply is by and for people who use drugs. And the prescriber models that I support here in BC are quite rigid. To access your safe supply through our programs, you have to qualify to have an opiate use disorder or a substance use disorder. In these programs, you have to adhere to a strict number of requirements to stay on your safe supply. It's hardly the liberation people who use drugs are demanding when they ask for an accessible and effective safe supply. These programs do benefit people, and they're being studied and evaluated so that we can innovate, but their ability to reach those in need is limited. Prescribed safe supply represents one part of a continuum of options that we need to see in order to actually stem the tide of drug poisoning deaths. But I'll put safe supply into a different perspective so that people can understand it beyond what we currently have, which is this prescriber model. If you go to a bar and you buy yourself a beer, you are guaranteed some degree of quality control. The alcohol percentage is predictable, and there's no chance that your beer has been cut with some dangerous adulterants like fentanyl. If a batch becomes spoiled, a process is in place to recall that product to protect consumers. Nobody would say that alcohol is 100% safe, but a regulatory process allows for consistency, which in turn allows consumers of that product to make informed choices. On July 9th, here in Vancouver, Mayor Ken Sim shotgunned a beer on stage, generating a lot of media attention. But could you imagine for a minute that one of those beers actually contained 11% fentanyl instead of the 4.5% alcohol? Probably not. It's hard to imagine that, because we forget that we actually have a safe supply of some drugs already in our country. And our culture of drugs for me, but not for thee, is wholly founded on racist and antiquated laws. We make these assumptions that there's a lot of people out there that understand what a safe supply is, but it's not actually true. There's little understanding about what a safe supply is. I was in a meeting once and I was lectured by someone who said that some drugs are legal because they're safe and other drugs are illegal because they're less safe. And it dawned on me that a lot of people actually have this belief. But you have to take a minute and understand that the truth is actually the opposite. We make drugs less safe and less predictable through prohibition. We promote safety and consistency through a regulated safe supply.
Great answer, Corey. Another thing that seems to keep coming up in the news that's more and more often is they're talking about diversion. And we're seeing that being a speaking point politically, where another word that's being weaponized as well. And so can we really kind of look at what diversion is? And are these concerns valid that are being, spread across the country? Leslie, maybe you can talk to that. Oh, muted.
I wanted to go back for a second to safe supply, to just the overview and where I work from in my mind and in my work is that we need to stop the deaths. That's where I start from, and a safe or safer supply that is low barrier, non-stigmatizing. What's the word I was looking for? Sorry, but across the board for all people who need them is the greatest harm reduction of all. We want to keep people alive so that not all the governments, some of the governments, certainly the BC government and the feds like to say that we're working on all these recovery and treatment, and we're pouring millions of dollars into it. And as we all always say, dead people cannot use those facilities. So my overview, and Corey dives deep, and so we learn from that what it could be, what it means, and how we wish it was. Okay, so to speak to diversion, I think there's, yes, the right politically in Canada uses diversion as the big boogeyman, around safe supply, that it will be diverted. It's always been diverted since drugs were around. We hear this from so many people. Diversion has always happened. Is it worse now? Are the outcomes worse? Are the unintended consequences worse? Maybe a little bit, and maybe not. We don't really have the information yet. Dilaudid, hydromorph, those drugs that are being diverted are in fact a safe supply. And I think the only scary part of that might be if a naive person, a drug naive person, were to think this is safe and buy some on the street. I mean, you can concoct these scenarios and takes 8 pills and they have never taken an opioid before. That might be a concern. Diversion is not a reason to vote against a safer supply.
Great, thank you, Leslie. I was just thinking too about diversion myself, and I look back historically that all substances have been diverted one way or another, and that's just something that we have to address. Just, teenagers getting people to go to the liquor store from them, taking alcohol from their parents' cabinets. I mean, that's a diverted substance. And so I don't, it's one of those things that we're hearing about it all the time. The risks, the benefits outweigh what risks there are. Drugs and substances have always seemed to be diverted. And I think that's just, we have to deal with that on a unique case by case basis, what's happening. Emily, do you have something to add to that, or?
Yeah, I just wanted to say, like you mentioned, Traci, alcohol, tobacco, cannabis, those get diverted to teenagers or people who are underage. And other medications are diverted as well. Even, something that there's a reason why the pharmacy sends out messaging saying, don't take medication that's not prescribed to you, because diversion is a thing. People might say, well, my doctor prescribed this for me. Why don't you try it and see if it works for you? And then with regards to the safer part of it, and I just wanted to go back and say that, I'm not trying to minimize the concern about diversion, because I understand, that it isn't necessarily safe for people to use someone else's prescription, but in a lot of cases it is. And I think it's a safer alternative to what some of those people have access to. And that's what it comes down to is what do you have access to? And so one of the fears that are kind of being generated through the media is this idea that because it's labeled safe supply, people think that it's safe to take. And I think you can relate that back to alcohol as well, because people think that alcohol is safe to drink because it's regulated, because it's widely consumed. By 70%, I think, of Canadians consume alcohol, but it's also not safe. And, you can't just drink alcohol as much as you want and expect that it's going to be safe. And it's the same thing with any substance, especially with opiates. With regards to the safe supply, one thing that right now there's a headline in Newfoundland that 17 people have died in the last few weeks from fentanyl poisoning because of the tainted drug supply. If that headline was 17 people died in the last few weeks from contaminated alcohol that they bought at the liquor store, we would have a very different public health response to that.
Yeah, that's exactly it. And, you know, Corey, do you have something to add? Because, I do recognize that, I think hydromorphone or Dilaudid is probably one of the most highly prescribed pain medications out there. And, a lot of that as part of the Safe Supply program, it's a very small fraction that are being prescribed to Safe Supply. The majority of the prescriptions are going to, pain management.
I think it's really important when we're talking about diversion, when we're talking about safe supply, to make sure that everybody has some kind of consistent definition to work off of first. And so, like, diversion itself is the redistribution of one's drugs to someone who is an unintended recipient. That could be selling a prescription, which is what the bulk of this conversation has been around so far. But it could also be splitting and sharing a dose with a friend. And it is very common practice in drug use culture to share your drugs with someone to help somebody out, especially if they're dope sick. There are studies out there about diverted methadone and the benefits that has shown to protect other people who are at risk of overdose or who weren't able to access medications on their own. But we do need to really look at these concerns and understand them and validate these concerns about safety, because for the most part, they're coming from a very genuine place of people being concerned for their children, they're being concerned for other children, and they're being fed a lot of scary misinformation. But we also need to cut through the sensationalism and the reactivity to make informed decisions. BC Coroner's Service report monthly that Safe Supply is not contributing to unregulated drug poisoning deaths. Reports from BC coroners and BC Center for Disease Control is that diversion of Safe Supply is not causing increased opiate use disorder or substance use disorder in youth or adults. And the fact that people are out there saying that Safe Supply is flooding the streets, that's categorically false, because there actually just isn't that much Safe Supply out there. Less than 5,000 British Columbians are able to access a Safe Supply in BC, and that represents about 4% of those in need. But one thing I'll say, just to close out my perspective as a nurse, is that we have a duty to provide the right drugs to the right people for the right reason. And right now, Safe Supply isn't meeting the needs of the majority of people who use drugs because we're actually not giving them the right drugs. Dilaudid or hydromorphone isn't the right drugs for every single person. And an example of that is that 68% of people who die by drug poisonings in BC are people who smoke their drugs. And right now, there exists 0 smokable Safe Supply options for people. And so if you're interested in addressing diversion, the answer isn't regression or punishing people or taking options away. It's actually expanding options. So we're meeting the needs of all people who use drugs.
It's a great answer. Kind of following along those lines of Safe Supply, we have found it's effective in not only helping those with an SUD, but it's a crucial step in curtailing death and poisoning events. Do we have any examples of that that you can speak of? Emily, maybe?
So I have 2 examples of Safe Supply, and they are just 2 stories, basically. One who had access to Safe Supply and one who didn't. I share both stories with permission. The first one is my own son. He had an infection and was paralyzed from the waist down. When he arrived at the local hospital, we had him transferred from where he was. He had been on hydromorphone for months and was very heavily addicted to it by that point, because he was, post-surgery. And the local physician who was taking care of him recognized that, he had a lot of other health concerns, and that substance use disorder wasn't the biggest concern that needed to be addressed. And so he, rather than talk about, how to get him off of the opiates as fast as possible, they talked long-term, and he decided to prescribe him Cadian. So he was given a prescription of Cadian so that he wouldn't need to go and source supply from the street and put him at greater risk for reinfection or for death. And then when it was time for him to, when he left here, he went to Ontario after leaving New Brunswick. And so in conversation with the physician, he gave him enough supply to get him there, and to get him, until he could find another source of supply. And when he arrived in Ontario, before he even ran out of his supply, he ended up, getting sick again, and he decided on his own that it was time for him to detox from opiates and to start his path to recovery. And so Safe Supply bridged that gap for him and helped him to get to the point where he was ready to stop using. The other example that I have is from a mom who, her son as a teenager, he became addicted to benzos, and when he got to a point where he realized, he could no longer continue to take them, and he wanted to get off of them. And these were illicit benzos that he had sourced through the dark web. He begged his doctor to help him, to prescribe him with Valium or something, so that he could help to taper off, because every time he's tried to stop taking the benzos, he would have seizures, and it was really affecting his health. He couldn't find a doctor who was willing to prescribe him anything to help him with tapering off the benzos. And then he happened to be in a freak accident where his foot was crushed by a car. And he also, because of his history, he didn't have access to any pain relief. And so, he was not prescribed anything for pain. So he had to source his own painkillers from the street supply, and that's what eventually took his life.
Oh, thanks for sharing that. It makes you realize how important it is that people get what they do need, that we would help reduce stigma across the line within healthcare in particular. And then, the education needs to be there for our medical providers. And that's, drastically missing here in Canada. Does anybody else have anything to add to that?
I was just going to briefly add my own story very briefly, because my son had been prescribed oxycodone for a back injury. He'd been taking drugs previously. He was solidly addicted to oxycodone, which was helping him. It made him feel normal. He had ADHD, and he always said that opioids made him feel normal. When our family doctor, who knew nothing about addiction, cut him off, that's when the trouble started, and he accessed a compendium of pharmaceuticals, which ended up stopping his heart. But he had inadvertently been put on Safe Supply, and he was doing well. He wanted to taper off, but he didn't have time to get there. So yeah, my story sort of echoes one of Emily's stories. Thanks.
Thanks, Leslie. Yeah. Corey, with the changes with Safe Supply, do you see that? How do you foresee that Safe Supply can help with curtailing death? And that's what we're here about. I mean, it's about saving lives. What steps moving forward do you see briefly that we could be taking and advocating for?
I mean, I see the benefits daily. I work in prescribed safer supply programs, and I speak directly with participants who are able to access these programs. I've worked with people who were overdosing multiple times a week and have stopped since being on their safe supply. And that's low-hanging fruit, but that's the most important low-hanging fruit, is that we stop people from dying. But I've also worked with people whose goals weren't necessarily to reduce or stop their drug use. They just wanted some more control in their lives, a return to functionality. And I've spoken to people who've said that they've finally been able to reconnect with their family because their safe supplies allow them to do something like engaging in having family conversations instead of the constant cycle of resourcing, sourcing, and then using unregulated drugs. There's no shortage of examples, but the problem is that these programs aren't super accessible. They have a very low capacity to meet people's needs. They often, we spend lots of times turning people away because we don't have space for people. And the vast majority of people who are at risk of drug poisonings do not want or need to see a doctor in order to access their safe supply. And so the future of safe supply is to take what we've learned in these small programmatic sites and then to break them out of these programs and to find accessible models that will meet the needs of the 90% of British Columbians who wouldn't be able to access one of these programs to begin with. And in order to see that, we'll actually need to see some courage from our politicians. We'll actually need to see some action from people who have the power to make regulatory changes so that we can see programs like Dolph's Compassion Club, so we can see programs that haven't even existed yet, like a public health approach to safe supply. All of that needs to happen. And in order to do that, we need to see our decision makers and our people in power actually listen to people who use drugs and implement their recommendations. There's a great study that just came out called Imagine Safer Supply from the Canadian Drug Policy Coalition that was completely community-led. And it says the same thing, that people want access to safe supply and they don't want to jump through a bunch of medicalized hoops and barriers in order to get it.
That's a great answer. Does anybody else have anything to add, Leslie? Along those lines?
Many things are going through my head about safer supply and access to, and you know, there's been a lot of comparisons for safer supply in my world, in my mind, I guess, and I don't think it's going to happen in my lifetime, that all drugs that people would like to access, such as MDMA, cocaine, opioids, and so on, stimulants, and other psychoactive substances, be controlled, but also be accessible, like as in liquor stores. Why are we doing this? Alcohol is incredibly addictive. We know that. It's a dangerous drug, but it is regulated. So it is about stigma. Our politicians do not have the will, the will or the courage. They want to keep their jobs. They are, I was going to say the word pandering, that may be not quite right, and a little strong, to the public, to the voting public. And the voting public is ignorant of a lot of the stuff we're talking about. And that is why we are here on this screen, why we're talking about this, because we need to advocate strongly to our local, to our MLAs, to our MPs, to our ministers, for what they already know is the right way to go on this. They know. I've been in committee meetings. They know. They've heard it. They know that they've had I think Corey referenced this, but it's not just the coroner's report. It's not the expert task force. It's not just Bonnie Henry. And BC Center on Substance Use. It's all the research shows that we must work on this widespread, low barrier access to a safer supply. So until it's done, we advocates have to be out there strongly advocating. And so why we're doing this webinar is to help you do that in the most effective and least scary way. So more power to all of you for spreading the word.
Great, thank you. One thing I, just kind of like to add to that is when it comes to advocacy, there's a lot of resources too that Mom Stop the Harm has on their website as well in regards to this. And, the best thing you can do is educate yourself. And, whether it's watching webinars such as this one or reaching out to other resources, definitely, we all, the stronger we can advocate for safe supply that meets the needs of unique individuals was what will move forward and help save lives. Hi, so great answers on safe supply. Was there anything anybody wanted to add before we move on to the next topic?
I would just like to add one little perspective, or, I'm good for the sort of things that could be made into memes, but to not implement safer supply in all its iterations, in all its pathways, is to exact death, tragic harms. So if we just make the corollary around it, just looking at it from the different direction, how can we not advocate for this in all its ways? And that's what I ask government when I'm ever in a committee. And they can't answer that question because there's a black box there. They say we're working on it. That's the famous phrase. They're working on it. how can they be working on it for 7 or 8 years and it has not yet happened, except in the wonderful, amazing pilot projects like Corey's involved in and other people. To not do it is inhumane.
I think that's something we can all agree on there.
Actually, I'm just going to jump in for a second. So, Leslie, you're referring to this pilot project that Corey is is involved with. Corey, could you maybe give us some information on that? Because not everybody knows Corey is Corey. Could you maybe give us a quick little highlight as to what that project is about, just as an example?
For sure. I mean, it depends on how quick is quick, but I am the clinical nurse specialist for AVI Health and Community Services Prescribed Safe Supply programs. We have 5 programs in total, 4 of which provide pharmaceutical alternatives, prescribed safer supply to people in Victoria, Nanaimo, Campbell River, and Comox Valley. And all of those programs provide varying degrees of fentanyl prescribed safer supply programs. And so there's an injectable sufentanil program that's a lot like an injectable opioid agonist therapy program, but more flexible. We also have a fentanyl patch program, fentanyl pill program called Fentora. We do the tablet prescribed safer supply as well, like the hydromorphone and Dilaudid. And we operate entirely through a flexible model. And what that means is that we are harm reduction centered, and we do our best to match people's preference for drugs with what we have available from a pharmaceutical standpoint. And then the 5th program that we have is the Safer Knowledge Translation and Exchange program, where we actually support other programs and organizations to scale up their own version of prescribed safer supply. And so that project currently is supporting an additional 9 prescribed safer supply programs across Canada, making for a total of 13 programs that we support in terms of trying to scale up safe supply through a prescriber lens.
Wonderful. Yeah, that's something that. How many of these? I'm just thinking, because here in BC, we're kind of like ground central for so many things, or ground zero. And are you finding that you're getting more interest for programs such as this from across the country, or is it?
I think what's important to talk about with this is that we are actually in the midst of a regressive swing. And while there is more scale up of prescribed safer supply through these smaller programmatic settings, the majority of people who receive their prescribed safer supply are not through these pilot programs. They're through, a one-to-one relationship with their GP, with their medical doctor, their primary care provider, with whatever you refer to. And the amount of prescriptions that people are able to access through that access point is going down. There are fewer people today on prescribed safer supply in BC than there was last month, and then there was the month before that. There is, at the very least, a quiet deprescribing campaign that is underway. And we're very concerned about the harms of that, because we know that deprescribing, forced deprescribing, particularly of opioids, often pushes people back to the unregulated drug supply, where the contaminants and adulterants are much riskier, much harder to predict. And that type of reactive prescribing practices poses a lot of risk for people who are currently benefiting from their safe supply.
And, in regards to that, is that something we're seeing coming down from the provincial, like a mandates changing at the provincial level? Do we see it? Is it from the College of Physicians and Surgeons? Where is that coming from? Do we think? Maybe you can address that, Leslie, or?
Yeah, I'm dying to address that. And I think, again, it is the political swing to the right, to the messaging by the Conservative government, that is simple and wrong, but simple, and people can grab that in sound bites and then go, oh, okay, I get it. This is what we need to do. Safe supply is enabling, and safe supply. Then there's diversion, all those things that are fairly simple concepts. So excuse me, the right wing or the farther right people who are vocal and visible, such as Polyev and his party, are well funded and are making a lot of headway, unfortunately. So and the right wing pressure, and I'm just this is just conjecture, is affects doctors and their prescribing, the college, all the powers that be. So this is why we need to advocate so strongly right now. We didn't think, well, I didn't think we'd be in this fight of fighting the rhetoric of the political right. I've just been advocating along for what I think and what we think are the best policies to support people who use drugs. And here we are having to strongly defend it against an enemy, I say an enemy, but challenges that we didn't know were going to loom up, or I didn't foresee it. So advocating, continuing to advocate for all the pathways of safe supply, advocating for physicians to be educated and to not be worried about their reputations and all of that. Yeah, and what Corey said, we're seeing that the reduction in the buy-in from physicians, and yeah, it's we're regressing, and we need to know that, and we need to push forward as advocates.
Okay. Emily, do you have something to add, or are you seeing that? We're definitely seeing that here in British Columbia. Are you seeing that in New Brunswick or in the Maritimes the same?
Not as much, because we're on a much smaller scale, and we're a little bit behind on the West Coast. So we have some programs here that maybe don't. They're kind of just getting started, and so, but we are seeing this far right narrative that's coming out, and people are really getting ramped up about that. So yeah, I feel like there is definitely a need for advocacy here, so that we don't, what little progress we've made with harm reduction and safe supply, we need to not let that regress, because it's definitely at risk if that message becomes kind of the generally accepted idea
Out there. Okay. So, like you've all kind of addressed this, is that we're really seeing more politicizing of harm reduction, both at the provincial and federal levels. And it's something that, like Emily said, it's that narrative that is being spread across the country. So, we're politicizing harm reduction, we're politicizing safe supply, we're politicizing weaponizing diversion. So a lot of those out there, people are starting to have those conversations about why are we continuing with this if it's not working, because it's a really negative message that's coming across. So there's basically they're saying harm reduction, we've tried it and it's failed. So how do we address that? How do we respond to someone who would rather us focus less on harm reduction, more on prevention, more on education and law enforcement? So one of the four pillars, but kind of we have the four pillars, but they want to leave out harm reduction. They really want to move forward with, the other pillars with that. Is that something you can talk about, Corey?
Yeah, I mean, the belief that we've tried harm reduction and that it's failed is actually incorrect as well. So there's actual evidence, which is what we have to lean on when we're faced with rhetoric and anecdotes that are founded in really, like, at the root, moralizing substance use. But but what little harm reduction we have been able to implement has already saved lives. And there's an excellent report from the BC CDC that basically demonstrates about 3,000 lives, 3,000 deaths have been averted because of the harm reduction efforts and the treatment efforts that have been implemented in BC since the declaration of the public health emergency. And so just, even at the core, the statement, we've tried harm reduction and it's failed, is incorrect. We've done a tiny little bit of harm reduction. And I want to explain to people how that actually works in our country. There is a piece of legislation, a very large piece of legislation out there called the Controlled Drugs and Substances Act. And this Controlled Drugs and Substances Act is a mutated body of laws from decades of antiquated drug policy and drug law that have been developed over time and that make it very, very difficult if you're a person who uses drugs to actually live and survive and thrive. And in order to implement a harm reduction service like a supervised consumption service, we apply to the federal government and they give us this thing called an exemption. And an exemption allows you to open an overdose prevention site or an SCS. And if someone comes and uses it, they won't get arrested. That represents a breadcrumb of what we actually need in terms of policy change and implementation of harm reduction services to create little spaces for people to use their drugs, but acknowledge that the drugs they're using are poisoned is actually very illogical. So we've only scratched the surface of what we should be doing for harm reduction, and what little we've done has actually helped. But if you want to apply the logic that we've tried harm reduction and it's failed, you should actually turn that over, that magnifying glass over to something like prohibition, because Canada spends $16.5 billion annually on municipal, provincial, and federal police operations. If you encounter someone saying we've tried harm reduction and it's failed, I would encourage them to apply that same logic to policing, because we've barely done a tiny bit of harm reduction. We've spent a fraction of what we spend on policing on harm reduction.
That's exactly it. And I know this is kind of off topic, but I just had a quick one if someone can speak to this. Is a misunderstanding of what law enforcement can do in regards to this, but we talk about defunding police at the same time. So we're not saying we're an anti-police, so we don't feel there's a need there for them. It's diverting or utilizing some of the resources that go to police to actually work, mental health and substance use, and having the proper supports in place at the same time. So, kind of taking everything out of that criminalized realm and putting it into mental health supports. So does anybody else can talk to what defunding looks like? Because I know, we're not saying let's get rid of police across the board by any means. It's a matter of switching resources.
Yeah, I think that's absolutely right. It's a matter of priorities of funding, and it's always been skewed. When I heard our Premier Eby come out with that figure of $1 billion going into the problem of the toxic drug crisis. Well, he didn't actually use those words. He wouldn't. And then I looked into it. Excuse me. $1 billion. So I looked into how much actually was allocated to safer supply. And out of $1 billion, it was 178 million. And I just was banging my head against the wall thinking, what is wrong here? We're talking death versus life. And you're saying, so I forgot what the question was, but I'm just going to continue anyway. Putting money into facilities and treatment is good, and regulating those organizations is good. We need all that stuff, but people need to be alive. So what was the question again?
The question was regard to reallocating resources away from criminal justice into mental health and addictions.
I think too, I was going to bring up decriminalization here in BC, and I've even heard, and for folks who maybe not aware of what it is, it's decriminalizing people, not drugs, people who carry 2.5 grams or less and are caught with that by law enforcement. there's even a messaging out there that decriminalization in its small way here in BC has actually increased deaths. And I don't even know what the reality people are, how they're coming up with that. And this is, again, politicizing this and weaponizing it. It's hardly a thing, this decriminalization of these tiny amounts of drugs. So I just hoping that people are aware that, make sure when you hear these things that it sounds reasonable. And if it doesn't sound reasonable, it probably isn't. And that's one of those things. The police, we can't defund the police. We can, well, it would be great if we could have sensitivity training. And I think they try to do it, but cops are cops.
Corey?
I just wanted to add to this, just so that people are aware, is that there is actual studies and evidence out there that shows police drug seizures will actually increase the volatility of the drug supply, and there will be increase in drug deaths in that area where the supply is disrupted. So going back to that original question of we've tried harm reduction and it's failed, no, actually we've tried the war on drugs for several decades now, and it has been a colossal failure that has led to many preventable deaths.
No, that's it exactly. And, you know, too, with disrupting the drug supply, it also increases violence, lateral violence within areas as well. So, you know, we're kind of just.
Can I add to that? Can I add to that, Tracy?
Certainly.
So I just wanted to say, like, with regards to the policing aspect of it, you know, if more law enforcement was the answer, the problem would already be solved.
Yes.
Because we've been pouring resources into that. And I saw a report, it was a report on the global drug policy. And they estimated that with less than 10% of the resources that every country currently dedicates to policing and law enforcement, they could actually implement full-scale harm reduction services that would save lives. And you know, so it's, when you're talking about defunding the police, people find that kind of scary. It doesn't mean getting rid of the police. It just means diverting a small portion of those resources into helping people rather than punishing them. And then I just wanted to go back and answer the last question, sorry, about harm reduction and you know, that it's failed, that kind of statement that it's not working. And you know, like the others said, the issue is that it's not enough. And there is good evidence to show that it does work. And with any other, you know, I gave some examples to a previous question about different types of harm reduction that aren't related to substances. And with any of those other examples, if they're not working, then we scale it up. We add more harm reduction measures rather than just get rid of them altogether. And, you know, an example of that would be the bicycle safety. So, you know, when I was a kid, they taught us how to safely ride our bicycles on the right side of the road, or whichever side of the road is supposed to be on. I'm not a cyclist. And how to use hand signals and watch out for vehicles. And then a lot of communities many years ago implemented mandatory bike helmets because people were being harmed riding their bicycles. And now in New Brunswick, there's that law where, you know, if you're riding on the road, that a vehicle has to give you the space to safely ride. So they scaled up the measures rather than just get rid of them altogether, which is what we need to do.
That's so true. And, you know, when we start trying to change the narrative and having these conversations with people, because it is becoming very divisive. It seems to be those who are very anti-harm reduction and those who are for harm reduction. And so those on the anti side, they really talk about harm reduction measures as being enabling behavior. And so that's something we need to address in that. It's because it's such a negative connotation behind the word enabling. You know, Leslie, do you have something you can talk to that on?
Yeah, here's what I would say to people who say that harm reduction is enabling people to use drugs. I say to them that you have never stood in my shoes, which are the shoes that have to contain the grief of losing my only child when he was 25 years old. if you had this experience, this is what I would say to people, you would be trying anything and everything to have to keep your loved one alive. Enabling should be rejigged, the word, to love. Love is what we have for our children. Love is what protects our children, how we protect our children. And I was accused of enabling my son because when our doctor cut him off the oxycodone, I went and accessed drugs for him so that he wouldn't get sick. He wanted to recover. We knew that. I was accused to the College of Physicians and Surgeons in a letter that I had been enabling my son. I was furious about that. And when we get angry about these things is when we begin action. Enabling is a word that we need to erase from this conversation. We need to redefine it. We need to understand that we as family members cannot carry that guilt. And that's what a lot of the rhetoric would have us do, is carry the guilt and enable our children or our loved ones to continue their addiction. That is incorrect. And I will, if anybody wants to talk to me offline about this, I can say a lot more. It's a blaming word, and we need to keep it in perspective, and it is about love and safety.
Really well said, Leslie. Thank you. Emily or Tyla, do either of you have something to add to that?
Yeah, I do. I 100% agree with everything that Leslie said. Enabling is a way that, to shame and guilt parents and keep them from, doing what they feel is the best for their child. For me personally, tough love never felt like love, and it wasn't something that I was comfortable with. And the thing, what I kept repeating to myself about my son was, I couldn't love him if I thought that I could change him, if I wanted him to be different than what he was. And so as far as enabling goes, I think we just need to flip the script and use enabling in a different context. So imagine saying, seatbelts enable people to drive recklessly, when the truth is they enable people to survive a car accident. Or, Ellen's law about cycling enables cyclists to take up space on the road and cause a lot of angst for other vehicles, when the reality is it actually enables cyclists to safely share the road. And so harm reduction, rather than saying that it enables drug use, it actually enables people to have better health and social outcomes.
Exactly.
I would totally agree. When, this has been some great insight, just even on this question. It comes back down to the evidence. I know in the earlier timeline of, and my family has been at this whole attaining lived experience for quite some time now. And, I look at where we were at the beginning of our journey to where we were maybe just a few years ago to where we are now. And, and I'm really glad, like, we've had the lessons that we have had, and I'm very fortunate on the fact that, our child is still alive. And same time though, I'm able to look at the world in a different manner. Everyone is going to have an opinion. Everyone's going to have a thought. Media only puts a bit of a splash of the actual essence of what is the reality out there, and then people just take it from there and just run with it in a million different directions. But in my journey of learning has been the fact of evidence. Where's the evidence to show as to why should I be looking at it that way? Where's that evidence to give me that direction as to tell me if I'm doing something wrong or not? This is a whole new level to some degree because of it being a different element of substances that are out there that we are dealing with. We can look back at history and we look at the prohibition and, the whole alcohol learning that we did. And now we're doing this learning with some, not just drugs in general, but just potency and the variables. Like it's just, it's mind blowing to the extent that it's gone to. But at the same time, where's the evidence and where can I learn as a mom who's trying to, save my child in all this, as to understanding? I know when we were first in the equation of it all, I had phoned the detox center and I'm like, okay, I don't understand. I don't know if my kid is high. I don't know if they're coming down. Like, I didn't even know proper terminology at that point. And I remember being told that, oh, she must be using that what's that drug called again? Oh, fentanyl. Where's that sticky so I can pull it up? Google didn't even have these answers to things, right? And to think of how far we've come, and yes, we have a very long ways to go, but amongst it all, in my role of having a loved one that was struggling, is the fact of there's love, and then there's unconditional love, and putting that right to the test. We will move mountains. We will go to the end of the earth to be able to not only bring these children into the world, and I'm speaking as a mom versus just any loved one, but at the same time to save our loved ones. And in the meantime, we don't realize how much learning and how much self-discovery and discovery and learning that's happening on the subject, and realizing how we have to filter out the white noise to what is reality and what is that evidence, to truly be able to have that clear brain to be able to make these decisions going forward. We don't just do knee-jerk reactions. We are responding because this is important. We are responding because this literally is life and death. But like I just always go back to those two, and amongst it all too, we're also having to learn how to take care of ourselves amongst it, because we very easily can get just totally encompassed with it, and just engulfed in that tar pit. But at the same time, we've learned a lot, and we're really just putting this kind of information out there and this sharing so that other people can learn that too, because we have everyone all across Canada, and we only speak because of being a national organization, but really it's all over the world. People are at every stage of the journey on this subject, from day one, figuring it out, to what you were dealing with. And there's even days before that, but really being able to start putting your mind around it, to being years later into it. And, it's a hell of a ride for sure, but at the same time, we always have to keep that focus. What is evidence-based, and what am I willing to do to keep my loved one alive, and what are within my resources that I have in my in my back pocket right now. At the same time, where can I grab those other resources to increase the that my toolkit that I have right at my side right now.
All right, great answer for that. Yeah, I think this is a subject right there that we could go on and on about. It's a lessons learned for everybody, who get on this journey and path. Corey, before we move on, do you have anything quick to add to that?
Yeah, I mean, I think the harm reduction as enabling trope is one that is as old as harm reduction. When needle distribution program started, we were told that was enabling injection drug use, but it turned out that was a very effective means to reduce the spread of HIV and hepatitis C. When we rolled out naloxone programs, people said that it was going to enable riskier drug use, but what it turned out to be a really great intervention to prevent death by toxic drug poisonings. And so again, it's just really important to cut through some of the sensationalizing and do some reality checking, because if these services are enabling, what exactly are they enabling? They're enabling human rights. They're enabling the right to choose. They're enabling safety. They're enabling people's ability to be alive and to have self-determination over their lives. And so to that effect, harm reduction is enabling, and that is a good thing that it enables those things. But there's also just the belief that harm reduction is enabling, that comes from a lot of people who feel like you need to hit rock bottom, and that you need to pick yourself up by your bootstraps, and that if there's a social safety net available, that people are never going to be motivated to change. And that's just contextually irrelevant in the current state of the drug poisoning crisis. People don't hit rock bottom and then decide they're going to make a change. People hit rock bottom and they're dead. And to a lot of people, rock bottom is 6 feet under, because one day that bump of coke that you do could actually be fentanyl and atizolam, and that's enough right there. There isn't any margin for error with how toxic the drug supply is.
That's exactly. That kind of brings us this enabling, conversation. Like, there's so many, topics here. We will expand on them in a future series on, kind of dig deeper into all of this. But moving forward with what some of our predetermined questions, though they all kind of segue one into the other, is we're also hearing a lot about involuntary care, which that's something that it's another, another hot topic right now. It's something that they're looking at in Alberta. Our government here in British Columbia, and I know they're talking about it nationally, has popped up, particularly in the Conservative Party rhetoric, involuntary care. And so who would like to start that conversation on that?
I wouldn't mind starting it anyway. This is something that we in committee and Mom Stop the Harm here in BC have been involved with for a while. There is a lot of evidence around the efficacy of involuntary care. Fact is, and the evidence shows, it actually doesn't work. It will, if a kid or a youth in particular, and we've dealt with this in BC, at least for now, is put into involuntary care. It does several things. It will keep that kid or that youth safe for as long as they're in there, because hopefully they can't access the drugs they need. But what will happen is they may go into withdrawal. But the other thing that happens is they lose trust in the people who put them there. That might be their parents. It might be law enforcement, in some policy. Or it might be even a physician. We don't know. It can be anybody can suggest involuntary care. What the dynamic is there is that they can hold, let's say there's a time frame that within which the service, if I want to call it that, can hold a person. What happens when they're released from that program? Has their trauma been dealt with? Has their addiction been dealt with? All the things that need to happen for a person to recover? Probably not at this point. Involuntary care is one of those simple solutions to a complex problem that the right is trying to, and the public say, yeah, throw these people into involuntary care. That'll do it. It gets them off the street. It gets them, it keeps us safe from those people. There's all kinds of reasons why this is popping up. So I would say, personally, I am against the concept of involuntary care. But the other side of the coin is, I talk to parents all the time, and I see the stories of parents who say, we must have involuntary care. We must get our kids into involuntary care, or our loved ones, because otherwise they will die. I understand that reasoning, but the fact is they could die anyway. What is the first thing a person in involuntary care for a short term is going to do when they get out? They're going to seek their community, their previous community of people who use drugs. We just don't know enough about what would happen inside that room of involuntary care. It's a scary concept, and I think we have to fight against it until we have the evidence that shows that this is going to be a positive experience for the person who's thrown in there.
Emily?
So yeah, I think it's important to note that, Mom Stop the Harm, we advocate for evidence-based treatment options. And when we're talking about evidence, we're talking about research. We're not talking about a Google search. And you can find all kinds of evidence either in news articles or on Google searches that are in favor of voluntary care or abstinence-based treatment programs. But that's because that's the traditional way that we have dealt with people with addictions. And so I think that, there is now evidence, there's real evidence. There are scientific papers that are published detailing and outlining what sort of treatment options are necessary for people. And I think it's important that we follow the evidence rather than follow the past practice. I know for my son, involuntary treatment would not have worked. Not a chance would it have worked for him. And so I never even considered it to try to do it, because I know that it would have been awful and I would have lost him forever. He never would have spoken to me again. Substance use disorder is a complex condition, and it needs a complex assortment of treatment options for people, because what works for one doesn't work for another. When you look at other health conditions, there are always a variety of treatment options. It's not a one size fits all. And with every other condition, we take an exhaustive approach. So if somebody doesn't respond to treatment, we try something else, or we increase the level of care that they get. But with substances, if this doesn't work, well, then you're on your own until you're ready to come and make this work for you. Rather than make the treatment work for the person, we expect them to fit into the treatment.
No, it's a great answer.
I'm
Corey?
just gonna jump in for a quick sec. Sorry,
Sure.
Corey. Just I know like earlier in a journey, like in our journey, something like the involuntary care, it's because then we can have the control over the situation. It's not, but at the same time, I also had to learn that it's not my control to have. It's my loved one's control to have as to what's happening for them. Where, because then that also gives us that gives us like a safety net that gives me a chance to be able to catch my breath, to be able to get some rest at night, knowing that they're safe. But the catch that happens is that whether it's involuntary care or they're willingly going into care, it is not long enough for them to actually be able to work through everything they need to be. A big 21 days to 30 days, or even if we get 45-day kind of programming, it is not long enough to actually be able to help you have that solid foundation, a positive, and have been able to work through everything to be able to move forward. And that's what we're expecting. This is just a quick fix. It's just it's because, well, mom says don't eat those cookies to spoil your dinner, where in essence, maybe you're hungry, you just need everything, right? Like you need to be able to have that balance, and it needs to be the person that is experiencing it to be able to be a part of those decisions, not everybody else in the world thinking they know best when they really haven't experienced walking in that person's shoes to be able to make those decisions.
I agree with that. And I think too that when we look at involuntary care, we have to look at the reasons behind why we're seeking it or why we want it. And it's generally for our own reasons. It has nothing actually to do with the other individuals involved. It's to give us respite or along those lines. But we also know that with involuntary care, there's a lot of research coming out and more being done. And whether it's in treatment or it's incarceration, remand, things along those lines, that actually increases the morbidity, mortality of those who have been kept in care one way or another. Is that something you can speak to, Corey?
Yeah, I think this idea of involuntary care, it feels important to talk about it. Also, to particularly to families, it feels like a vital option, and that often is because it feels like there are no other options available. And so the first thing that I wanted to say is much the same as we often struggle with messaging around defunding police. It's because we do a poor job of illustrating what the world could look like if this option was not available. And to some, that feels like if we took away the option for involuntary care, that there would simply be nothing there for people. But if we actually look at what involuntary care does, what involuntary detention of people who use drugs does, the evidence that is available out there shows that it will actually increase risk for death. It confines people to a space, it drops their tolerance, and then when they are released back out into the community, relapse is incredibly common, but they also have no tolerance, making for a recipe for preventable drug poisoning death. But it also means that people are going to use in isolation, because whoever committed them, whoever involuntarily detained them, is no longer a trustful person to them. It also means that if they get into trouble and they're seeking out support, that they're very unlikely that they're going to seek out support through healthcare services, because healthcare services just recently infringed on their rights and confined them to a space against their will. But it's also really important to assess this as what it is, which is it's not actually a new idea. Controlling, surveilling, and detaining people is as old as the colonization of this land. It is criminalization by another name. The new idea is actually just the old idea that created the problems that we're in right now. And if you look at Alberta's proposed Compassionate Intervention Act, if you look at some of BC's municipalities that are trying to roll out public drug consumption bylaws, these are all just opportunities where people of color, Indigenous people in Canada can continue to be disproportionately impacted by criminalization. And a principle of harm reduction is that options for treatment must be evidence-based, accessible, and here's the kicker, non-coercive. And so this is not if we take away this option, you suddenly won't have options for your loved one. It's that we need to advocate for a whole suite of options, whether it's safe supply or regulated treatment options. Wherever you are in your drug use journey, you have it available on hand, and it's accessible, and it is tailor-made according to your needs. And so to that effect, we need to break out of that mindset that involuntary care is the last ditch option and move towards how can we create this continuum of options so that we never have to think about involuntary detainment again.
Well, I would like to thank all of our panelists today. It's been a really great conversation, and one that probably could go on and on, definitely. So, one of our last things I wanted to do is a really brief statement from all of us here, in what you can do in regards to advocacy, about any of these topics, before we close. And maybe I can move that over to Emily for a final statement.
Sure. So what I usually tell new advocates is to watch as many webinars as you can, read as many articles as you can, read books about the topic, and especially ones that you hear through Mom Stop the Harm, because they're ones that are aligned with our mission, vision, and values. And then you can speak confidently. As you read enough and you absorb enough information and you hear others speak, then you can speak confidently to issues and to questions when you get them. And then the other thing that I always tell people is to reach out to your local harm reduction agencies and partner with them in any way that you can. And then that's how I got started with getting involved in local events and meeting people, was through that local harm reduction agency.
Thank you. Leslie? You're muted.
We always say this, and we say it over and over because it's relevant, and that is find out how to contact your local MLA, your MP, write letters to the ministers, see if you can get on committees, all of that, because that we don't have a lot of political clout if we don't do that. But the other thing to remember is Mom Stop the Harm has great presence in Canada right now and will continue to have. People in the federal government that are working on this file, they all know about us. They all respect us. They will even contact us for information or opinions. So we need to continue to have our presence front and center. We need to, another thing we can do once we feel confident in our public speaking, and you can do it in front of the mirror and you can do it in front of your loved ones, and not throw fear out the window, is that we need to continue to be in the media, write op-eds, sometimes I call CBC and say, hey, we need to comment on this. Can you put us somewhere? And inevitably they will. So we need to use that power. We need to leverage our visibility all the time. So it's really important for all of us and people watching this who haven't done it before to be to shake off the fear and just speak your truth. We have to, as they say, speak truth to power every single day. And I know we can. I'd like to say I know we will win this. I'm going to say that. I know we will win this for what we need. So I just thank everybody for watching us, and hopefully you agree and learn something.
Corey?
Yeah, I mean, I'll echo all of the great insight that's already been said. Before you jump into things like direct action and protesting at your legislature or speaking to the CBC, a really great first step everybody can take is to listen to people who use drugs and to hear their stories, to read the publications that they put out, to follow and understand the recommendations that they're issuing, because the principle of nothing about us without us is paramount to doing this work in a meaningful and equitable way. And so the first thing you can do to be an advocate is actually to listen. And instead of going down the same route as the other panelists today, I will say another thing you can do as an advocate is to apply the principles of harm reduction inward. Look at how you practice on a day-to-day basis. If you're a care provider, if you're a social worker, whatever you might do, and how can you practice from a harm reduction perspective? Apply those principles to your own organization. Are there policies and protocols in place that are causing harm to people? Because truthfully, nothing you can do right now will change the system overnight, but everything you do today can help the people. And so if you're mired in the fact that this all feels too heavy, too big, I can't do this on my own, you don't have to. Start with one interaction, start with one family member who's on the fence about harm reduction, and take that task on.
These are all great suggestions on how to move forward with advocacy. And Tyler, do you have something to add to that?
Actually, Traci, I'll let you have conclude your closing remarks, and then I'll add in a few additional resources and such too. So go ahead.
Okay, great. Well, I really appreciate the panelists that we had here today and for you joining us in this really valuable discussion. There's a lot of knowledge and wisdom amongst those that are sitting here and talking to this crisis. Like Leslie says, I'm going to echo that. I do feel that we will win this. You know, we have to have that hope and we will win. Little incremental wins out, you know, as we move forward, but, you know, we take it as it is. Again, thank you for joining us. Thank you, panelists. And I hope you join us for more as we develop this series.
Well,
Thank
definitely
you.
thank you everyone for joining us. One thing that you know, I guess I would build upon what our panelists have said is, you know what, just share your story. It's what you know, it's what you've learned, and other people can learn from your story. So definitely share it, you know, scream it loud and proud, and just make sure that, you know, someone is listening, because we don't have the necessarily the stats to show how many people have maybe learned something from us sharing, but at the same time, we do see the ripple effect of things changing. The other thing that I would also like to just quickly remind everyone is to remember to breathe. Remember to take that deep breath and really focus on breathing when we are coming together, whether it's actually at our advocacy events or just having conversation. Self-care is so important. And one thing about self-care is definitely remembering to breathe. It has a whole scientific impact on our being, but at the same time, it just helps us to be able to calm those nerves, get rid of those butterflies, and just to be able to focus. We know what we want to say, but at the same time, it just helps us to be able to have that focus. And it's also very healing. So remember, please, you know, and allow yourself to be able to process, you know, breathe and process the weight and the topic and all the information that that this topic brings forward for us. The other thing is, don't forget, breathing is only part of self-care. Do things that make you smile, that bring joy and bring peace to your world, because that's so important. And we have to have that life balance in all areas. But again, thank you everyone for coming out today and for tuning in. We are going to have this posted on our YouTube channel. So there's this resource and many, many more on the Mom Stop the Harm YouTube channel. You can go to YouTube, search Mom Stop the Harm, and you'll find a whole wealth of resources such as this. And the other one is momstoptheharm.com. That is our main website, and that'll give you a whole plethora of information, give you some stances, all the stances of what we stand for as an organization, lots of resources, as well as our contact information. So definitely please reach out. Don't hesitate. If there's someone specifically you'd like to be able to reach to connect with and have further conversation, that you can access us all through our website. All right, have a great day. Thank you.